Welcome back to the deep dive. Today, we're charting some really intricate territory. We're talking about the human core specifically, the hip and pelvis.
Yeah, and not just the anatomy, but the geometry behind imaging it correctly. It's surprisingly mathematical.
Exactly. It's like medical cartography. We're diving into the precise angles, the rotations, the landmarks you absolutely have to nail in radiography to get a useful image.
Our source material here is basically the rulebook technical manuals on localization, positioning, evaluating images for things like AP views, obliques, even those tricky axial shots.
So our mission for you listening is to really get why it's so specific. Why does rotating a foot 15 degrees suddenly make the femoral neck visible? We want you to grasp the geometric logic behind it all. Okay, let's get into it.
And maybe to kick things off, let's throw out a little localization puzzle right from the manuals. Radiographers use points they can feel, palpable landmarks. So here's one. What common, easily felt landmark is actually on the exact same horizontal level as the pubic symphysis.
Ooh, that's a good one because, they feel quite far apart, don't they? One's midline low, the other's out to the side.
Mm-hmm.
We'll let you think on that. The answer involves the greater trochanter, which, as we'll see, is a landmark with...
Well, let's just say it has multiple personalities depending on exactly where you touch it.
That's putting it mildly. Getting the right point on the trochanter is critical. It really is a game of millimeters and degrees sometimes.
Okay, so let's build the foundation. The hip bone, the os coxae, it looks like one solid piece in an adult, but it starts as three, right?
That's correct. It's a fusion. You've got the pubis, which is sort of the front and lower part.
Right.
Then the ilium, that big flared part you feel at your waist, the superior bit.
Yeah.
And finally, the ischium, the posterior and inferior part. That's your sitting bone, basically. Knowing these three is fundamental, especially when we get into trauma views looking for fractures in specific columns of the acetabulum.
Like the iliopubic versus the ilioscale columns you mentioned.
Exactly. You need to know which part is which. But for just positioning the patient day to day, it's more about the outside landmarks, the bits you can actually palpate reliably, which are the absolute go-to point.
Oh, definitely three main ones. The anterior superior iliac spine, or ASIS. That's probably the #1 reference.
That bony point at the front of your hip crest.
That's the one. Then the pubic symphysis, right in the midline down low. Crucial for centering.
Okay.
And the iliac crest itself, the top ridge, that flared ilium. That helps you set the upper border for your image receptor, your IR.
Yeah, the source material says what? Place the IR about an inch and a half above the crest for an AP pelvis?
1 to 1.5 inches, yeah.
Yes.
2.5 to 3.8 centimeters. Precision matters.
Okay, back to that trochanter puzzle. You said the greater trochanter has different points meaning different things. Let's unpack that.
Right. So the highest point of the greater trochanter, if you feel for the very top edge, that point is actually in the same horizontal plane as the midpoint of the hip joint itself, and also the coccyx, the tailbone.
So that gives you a level for the joint center?
Exactly.
Right.
If you find the most prominent point, the part that sticks out the furthest laterally, that point is in the same horizontal plane as the pubic symphysis. And that solves our little quiz.
Ah, okay. So the widest point laterally lines up with the pubic symphysis midline. That's fascinating and easy to mix up, I bet.
Very easy. And if you use the wrong trochanter point for centering, you could be off vertically by a significant amount, centimeters, easily.
Which underlines the whole theme. Localization isn't just finding a bony landmark, it's finding the specific geometric point on that landmark.
Precisely.
Which brings us to finding the hip joint itself, the acetabulum. The manuals give a kind of geometric shortcut, right? Using lines.
Yeah, it's actually quite elegant. You don't need to guess. First step, palpate the ASIS and the top edge, the superior margin of the pubic symphysis.
Okay, got those 2 points.
I imagine a straight line connecting them.
Right, like drawing a line on the skin mentally.
Exactly. Now find the midpoint of that line.
The halfway point between the ASIS and the pubic symphysis.
Correct. That midpoint is directly superior to the center dome of the acetabular cavity. That nails your location for the hip socket.
Okay, that finds the socket. But what about the ball, the femoral head, and the neck connecting it? How do you find those without just guessing?
More geometry. You take that midpoint you just found, and now you imagine a second line drawn at a right angle, perpendicular, to the first ASIS to pubic symphysis line, starting from that midpoint.
Okay, so a line shooting off at 90 degrees from the center of the first line.
Yes, and that perpendicular line runs parallel to the long axis of the femoral neck. It basically points down the neck of the femur.
Wow. Okay, so you've built a little coordinate system just using those two palpable points.
Pretty much. And it gets even more specific.
Mm.
If you measure down along that second perpendicular line,
Yeah.
about 1.5 inches or 3.8 centimeters, distal from the midpoint, you found the center of the femoral head.
Right over the ball of the joint.
Yep. And if you go further down that same line to 2.5 inches or 6.4 centimeters distal, you're right over the center of the femoral neck.
That's incredibly precise and completely non-invasive, just based on surface landmarks and geometry. Crucial for getting a true AP view of just the hip, I imagine.
Absolutely crucial. And like you said earlier, it's also a check. If the patient's rotated, these geometric relationships just won't hold up.
Okay, let's transition from finding the points to actually taking the picture. The standard AP pelvis view, you mentioned symmetry is key here.
It's non-negotiable because you're often comparing left to right, looking for subtle differences, maybe early signs of disease or injury. So the baseline has to be perfectly symmetrical.
How do you ensure that?
Well, first, the patient's median sagittal plane, that line dividing them perfectly left to right, has to be dead center on the table in the IR.
Okay.
And the practical check is to feel both ACES points. The distance from each ACES down to the tabletop must be exactly the same. If one side's higher, the pelvis is rotated. Simple as that.
No tilt allowed. Flat as a pancake. But then, once you've got that perfect symmetry, you deliberately introduce asymmetry, don't you, with the legs? The medial rotation rule.
Ah, yes, the famous 15 to 20 degrees. Once the pelvis is locked in position, you immediately rotate the feet and the entire lower limbs inwards.
Towards each other.
Towards each other, yes,
Sure.
by 15 to 20 degrees. This is probably the single most important positioning step for getting a good look at the femoral necks on a standard AP pelvis, assuming no trauma, of course.
Right, the trauma exception is huge. Don't force anything if there's suspected fracture. But assuming no trauma, why that specific 15-20 degree inward turn? What geometric problem is that solving?
It's solving the natural anatomy of the femur. The femoral neck doesn't come straight out from the shaft. It angles forward anteriorly, usually by about, 15 to 20 degrees.
Ah, so the rotation counteracts the natural forward angle of the neck.
Precisely. If the feet are pointing straight up, the neck is angled forward relative to the IR, so it looks foreshortened, shorter than it really is. And that bump on the back, the lesser trochanter, sticks out prominently. By turning the whole leg inward 15 to 20 degrees, you effectively cancel out that forward angle. The femoral neck becomes parallel to the image receptor.
And that's why you see it in its true length and profile. It's literally a geometric correction factor.
Exactly. And if you get that angle wrong, say you only rotate 10 degrees,
Yeah.
the neck will still be somewhat foreshortened. The lesser trochanter will still be visible posteriorly. It compromises the diagnostic quality. 5 degrees can make a difference.
Wow. So that precision is critical.
Yeah.
And you mentioned the IR placement top edge, 1 to 1.5 inches above the crests. What about the central ray, the CR? Where does that beam enter?
Also very specific. It's perpendicular to the IR, straight down, assuming the patient is flat. And it enters at a point that's defined by both the ACES and the pubic symphysis.
Oh, so.
The entry point is 2 inches, or 5 centimeters, inferior to the ACES level, any 2 inches, or 5 centimeter, superior to the pubic symphysis level.
Okay, so halfway between a point 2 inches below the ACES and a point 2 inches above the symphysis?
Right. That spot effectively targets the center of the overall pelvic cavity, giving you good coverage of everything.
All right, so the picture's taken. Now, quality control. How do you look at that AP pelvis image and know, yes, the positioning was perfect? What are the geometric checks?
Several things. First, overall symmetry. Assuming no underlying pathology causing asymmetry, both iliac wings should look pretty much identical in shape.
Okay.
And the obturator foramina, those two big holes at the bottom, they should be symmetrical in size and shape. If one looks rounder and the other more oval, the pelvis was rotated.
That's a dead giveaway for rotation.
Oh, yeah. And you also look at the ischial spines, those little points sticking inwards. They should look equal. The sacrum and coccyx should be lined up right over the pubic symphysis, indicating no tilt.
Makes sense. But what about checking that crucial 15-20 degree leg rotation? How do you confirm that was done correctly?
You look directly at the femoral necks. Are they seen clearly in their full length without looking artificially short? That's check number 1. Then you look at the trochanters. The greater trochanters, the big bumps on the outside, should be seen in profile laterally. But the real telltale sign is the lesser trochanter, that smaller bump on the medial side of the femur posteriorly.
Right. What about it?
If that 15-20 degree medial rotation was done correctly, The lesser trochanter should be mostly hidden behind the femoral shaft. You might see just a tiny bit of it peeking out on the medial edge, or none at all.
Ah, so if you see the lesser trochanter sticking out clearly behind the femur.
It means the leg wasn't rotated enough medially, or maybe it was even externally rotated. It's like a little gauge for leg position. Seeing that lesser trochanter prominently means the femoral neck isn't truly parallel to the IR.
That single bony bump tells the whole story of the rotation. Amazing.
It's a perfect geometric indicator.
Okay, so that covers the standard overview AT pelvis. But sometimes you need to zero in on the femoral neck itself, maybe looking for subtle fractures or other issues like a vascular necrosis. What views help there?
That's when you move to specialized projections. A common one is the AP oblique for the femoral necks, often called the modified Cleaves method, or sometimes the frog leg position, although that term can be a bit imprecise.
Frog leg, right. I've heard that. What's the geometry involved there?
The whole point of the modified Cleaves is to get the greater trochanter out of the way because it can overlap the neck in the standard AP.
Okay. How does it do that?
For the bilateral version, where you look at both hips at once, the patient's pelvis stays flat, no rotation, centered on the table.
All right.
Then they bend their hips and knees, pulling their feet up towards their body. Usually, the soles of the feet are placed together for support.
Okay. So knees bent, feet up.
And here's the key geometric move.
Yeah.
They abduct their thighs, letting their knees fall outwards maximally and equally. The target angle, according to the source material, is about 45 degrees from the vertical.
45 degrees outward abduction for each thigh. That's quite a stretch for some people.
It can be, yeah. But that specific 45-degree angle is what rotates the femoral neck out from behind the greater trochanter, projecting it more clearly.
So the abduction is the critical variable here.
Absolutely.
Yeah.
And the CR for the bilateral view is perpendicular, aimed at the midline, about 1 inch, 2.5 centimeters above the pubic symphysis.
What if someone can't do both legs, say, due to trauma on one side?
Then you do the unilateral version. You only position the affected side. You'd center the ACES of the affected hip to the midline of the grid.
Okay.
Then you'd have the patient flex that hip and knee, maybe resting the foot against the opposite knee, and again, abduct that affected thigh outwards, aiming for that same 45-degree lateral angle.
In the CR.
For the unilateral, the CR is perpendicular, but aimed directly at the femoral neck of that affected side, using that localization geometry we talked about earlier.
Got it. So how do you evaluate the image? How do you know if that 45-degree abduction worked?
The main criterion is simple. Is the femoral neck seen clearly, without the greater trochanter overlapping it? If yes, the angle was likely correct.
But you mentioned a trap.
Yeah, there's a geometric catch. If you abduct too much, say way more than 45 degrees, like 60 degrees or something, the greater trochanter can actually swing back into the field of view and obscure the neck again from a different angle. So 45 degrees is kind of the sweet spot. Not too little, not too much.
A delicate balance indeed. And you'd also check that the angles look symmetric if it was a bilateral view.
Exactly. The shafts of the femurs should look like they're coming off the pelvis at equal angles.
Okay, that makes sense for planned obliques. But now, the really challenging scenario. Trauma. Patient can't move, maybe has a suspected hip fracture. How do you get a lateral view of that hip?
Now you're talking about the axiolateral hip projection. The classic cross-table lateral, often called the Denelius-Miller method. This is where the geometry gets really creative, because the patient is often totally immobile on their back.
So you have to move everything else around the patient.
Precisely. The equipment and the patient's unaffected leg.
Right. First step is getting the good leg out of the way, isn't it? That seems critical.
Absolutely critical. You need to flex the knee and hip of the unaffected side as much as possible, bringing the thigh up to be almost vertical.
Pointing towards the ceiling.
Exactly. And then you rest that leg or foot on some kind of support pillows, a stand, whatever works, to hold it there. The goal is to prevent the shadow of that healthy thigh from overlapping the injured hip joint on the image. That's a common error that ruins the view.
Okay, unaffected leg, up and out of the way. What about the injured leg?
Ideally, if it's not contraindicated by the specific injury or the doctor's orders, you'd still try to get that gentle 15 to 20 degree medial rotation.
To profile the neck.
Yes. But realistically, in many trauma situations, you just can't or shouldn't move the injured limb at all, so you image it as it lies. The key is zero rotation of the pelvis itself. It must stay flat.
Okay, pelvis flat, good leg up, bad leg still, maybe slightly rotated. Now, the IR and the beam. This is where it gets complex, right?
This is the geometric puzzle. The image receptor is placed vertically, like a wall, against the patient's injured side.
Okay, upright cassette.
Its top edge needs to be up in the crease above the iliac crest to make sure you capture the whole joint.
Right.
And here's the crucial part. The IR isn't just placed straight vertically against the hip. You have to angle the bottom edge away from the body
Okay.
until the entire flat surface of the IR is parallel with the long axis of the femoral neck.
Whoa. Okay. Parallel to a structure you can't even see directly on an injured patient. How on earth do you judge that angle?
It takes practice and a good understanding of that localization geometry we discussed. You use the ASIS and pubic symphysis line, imagine the perpendicular line for the neck axis, and try to align the IR parallel to that imaginary line. It is definitely challenging.
Why does it have to be parallel? What happens if it's not?
Foreshortening again. If the IR isn't parallel to the neck, the X-ray beam, which comes in horizontally.
Right. The beam is horizontal, shooting across the table.
Yes, the CR is horizontal and aimed perpendicularly at the femoral neck. If the IR isn't parallel to the neck, the image projected onto it will compress the neck's length.
Yeah.
It makes it hard to accurately assess fractures, especially displacement or angulation. Parallelism ensures you get the truest possible profile and length.
So the horizontal beam hits the perpendicular point on the neck and projects onto a parallel IR. That's the definition of a true lateral.
That's the geometrical.
Okay, and checking the resulting image, what confirms success?
3 main things. 1, femoral neck seen clearly without the greater trochanter overlapping it. That confirms your parallelism worked.
Okay.
2, you should be able to see the ischial tuberosity, that sitting bone, again visible just below the image of the femoral head and neck.
So it shouldn't overlap the joint space.
Correct. And 3, critically, no significant shadow from the unaffected thigh overlapping the hip joint or the proximal femur. If that leg wasn't lifted high enough, its shadow can obscure important details.
Man, that sounds tough to get right consistently. What if that setup is just too difficult? Patient size, room constraints. Is there another way?
There is. The source material described a modified axial lateral, the Clements-Nakayama modification. It tackles the geometry differently.
How so?
Instead of wrestling with a vertical IR held parallel, this method uses the Bucky tray under the patient. You place the grid IR flat in the tray.
Okay, so IR is horizontal now, under the hip.
Initially horizontal, yes. First, you adjust the grid so it is parallel to the axis of the femoral neck, just like before, but lying flat. Then, and here's the twist, you tilt the top of the IR backwards by 15 degrees.
So the IR is now angled 15 degrees back from horizontal.
Exactly. And the CR compensates. Instead of coming in perfectly horizontal, the X-ray beam is directed 15 degrees posteriorly angled towards the feet and aligned, so it's perpendicular to both the femoral neck and that tilted IR.
Ah, it's a coordinated tilt. You tilt the IR back 15 degrees and you angle the beam down 15 degrees to match it.
Precisely. It's a geometric compensation that achieves essentially the same true lateral profile of the neck as the Donnelius Miller, but often with less physical hassle, especially if holding the vertical IR parallel is proving difficult. It's quite clever.
Very elegant solution to a tricky problem. Okay, we've covered the femur pretty thoroughly. What about the socket it sits in, the acetabulum? Standard A keys don't show that cup very well, do they?
Now, the acetabulum is a complex 3D structure. For suspected fractures of the rim, or the supporting columns, you need oblique views. These are often called the Judith views.
Judith views. Okay, what's the geometry there?
They are essential for checking the integrity of the acetabular rims, the front and back edges, and those 2 main bony columns that support it, the iliopubic column, anterior, and the iliuscal column, posterior. Both Judith views use the same basic rotation, a 45-degree posterior oblique.
So the patient is rolled halfway onto their back.
Exactly, 45 degrees oblique. But which side is up or down determines which part of the acetabulum you see best.
Okay, let's break that down. There's an internal oblique and an external oblique. Which is which?
The internal oblique is when the affected side is UP, away from the table.
Affected hip raised 45 degrees.
Yes. This position profiles the posterior rim of the acetabulum and the iliopubic anterior column. They sort of rotate into view away from the center.
And the CR?
Perpendicular beam entering about 2 inches, 5 centimeters, inferior to the ASIS of that affected raised side.
Okay, internal oblique, affected side up, affect posterior rim and anterior column. What about the external oblique?
External oblique is the opposite positioning relative to the affected side. Still a 45-degree posterior oblique, but now the affected side is down, yin, closer to the table.
Affected hip down 45 degrees.
Right. And this position profiles the anterior rim of the acetabulum and the ilioischial posterior column.
And the CR for this one.
Also perpendicular, but this time it enters at the pubic symphysis.
So the 45-degree rotation is the key, but whether the injured side is up or down determines which specific structures you're highlighting.
Exactly. That 45-degree geometry is perfectly designed to isolate either the front or back components of that acetabular cup.
Fascinating. Now, for the final frontier of pelvic geometry, the axial views, these use really extreme angles, right, to look through the pelvis.
Yeah, these completely change the game. Instead of a perpendicular beam, you're using steep cephalad towards the head or caudad towards the feet angles. The whole point is to open up the pelvic ring, looking down the inlet or up through the outlet, avoiding the overlap you get with a standard AP.
Essential for seeing the whole ring structure, especially in major trauma.
Absolutely. You need these angles to assess ring integrity.
Okay, let's start with the view looking up from below. The AP axial outlet, sometimes called the Taylor method, this shows the lower front parts, the pubic and ischial bones. Which way does the beam angle?
For the outlet view, the CR is angled cephalad towards the head.
Upward angle, where does it enter?
Midline, about 1 to 2 inches below the top of the pubic symphysis. You're basically aiming the beam up through the pelvic arch.
Okay, and the angle itself, is it standard?
Here's where it gets really interesting, and it's highlighted in our source material. The angle depends on the patient's biological sex.
Oh, how so?
For males, the required cephalad angle is typically 20 to 35 degrees.
Okay.
But for females, you need a steeper angle, 30 to 45 degrees cephalad.
Wow, that's a significant difference, potentially 10 degrees or more. Why the variation?
It's pure anatomical geometry. The female pelvis, on average, is wider and shallower than the male pelvis. The plane of the pelvic outlet is angled differently relative to the body. To get the beam to pass cleanly through that outlet arch without being blocked by bone, you generally need that steeper upward angle in females.
So the anatomical differences directly dictate the required geometric approach? That's a perfect example of what we're talking about today.
It really is. And it means the technologist needs to know the patient's sex and apply the correct angular range. It's not one size fits all. You might even need to adjust within that range based on the individual's build. Maybe a narrower male pelvis needs only 20 degrees, while a very broad female pelvis needs the full 45.
It requires judgment based on anatomy.
Exactly. Customized geometry.
Okay, so that's the outlet view, Taylor, looking up. What about looking down into the pelvic bowl, the inlet view?
That's the AP axial inlet view, sometimes called the Bridgman method. And as you'd expect, it uses the opposite angle.
So cauded, towards the feet.
Correct. A steep angle, 40 degrees caudad.
40 degrees down, where does that enter?
Midline, but higher up this time at the level of the ACES points.
Okay, aim 40 degrees down from the ACES level. What does that show?
That steep downward angle projects an image of the entire pelvic inlet ring. It effectively looks straight down the barrel of the pelvic bowl, showing its overall shape and integrity. It distorts things like the sacrum, but opens up that crucial inlet ring.
So Taylor outlet is cephalad angle, Bridgman inlet is caudad angle. Got it.
Two sides of the same coin, using extreme geometry to visualize the ring structure.
Okay, we've walked through a lot of complex positioning and angles. Let's synthesize this. When you look at any of these images, AP, oblique, axial, what fundamentally defines success? What makes it a perfect diagnostic image?
Well, beyond just getting the right anatomy in the frame, the absolute goal is clarity and detail. You need to see the fine, mesh-like structure within the bone, the trabecular detail.
Right, it tells you about bone health.
Exactly. And you need to see the outlines of the surrounding soft tissues clearly. If there's any hardware, like screws or plates from a previous surgery, that entire appliance needs to be visible, no part cut off. That's critical for orthopedic follow-up.
Makes sense. What about confirming the geometry worked for those tricky axial views? If you took a Taylor outlet view with the correct cephalad angle, what should the image look like?
For the Taylor outlet, because of that upward angle, the pubic and ischial bones will look somewhat magnified and elongated because they were closer to the X-ray source.
Yeah.
The key geometric check is that those pubic bones should appear superimposed over the sacrum and coccyx. That tells you the beam passed cleanly through the outlet arch. And naturally, you still need symmetry. The obturator foramina should look equal, proving you were centered correctly.
Got it. Pubics over sacrum equals good outlet angle. Now the Bridgman inlet with the 40-degree cutout angle, what's the geometric proof there?
That steep downward angle causes a specific pattern of overlap. You should see the superior and inferior pubic rami, The upper and lower bars of bone forming the front of the obturator foramen, appearing superimposed on top of each other right near the midline.
Okay, overlapped in the middle.
And further out laterally, the pubic bone and the ischial bone behind it should look nearly superimposed as well. If you see distinct separation there, or if things look skewed, the 40-degree angle probably wasn't right, or the patient was rotated. That specific overlap pattern is the signature of a correctly angled inlet view.
It's amazing. The evaluation itself is entirely based on understanding the geometric distortions created by the specific angles used.
It really is. You're validating the geometry by looking at the resulting projection.
Okay, just to circle back and really hammer home the basics before we wrap up, let's quickly recap the two most fundamental positioning rules we discussed for standard hip pelvis imaging.
Sure. Number one, for the routine AP pelvis, unless contraindicated by trauma, the lower limbs must be medially rotated 15 to 20 degrees. That's the key to seeing the femoral necks properly.
15-20 degrees internal rotation. Got it. And number two, the specialized view that requires that big 45-degree outward swing of the thighs.
That's the AP oblique for the femoral necks, the modified Cleese method. That 45-degree lateral abduction is its defining geometric characteristic.
Perfect. Okay. So pulling all this together, this has been a fascinating journey through really applied biomechanical geometry.
Yeah, it's way beyond just knowing bone names. It's about the spatial relationships, the angles, the planes, how the X-ray beam interacts with this complex 3D structure.
And how diagnosis can hinge on getting a measurement right, 1.5 inches versus 2.5 inches, 15 degrees versus 20 degrees, 35 versus 45 degrees cephalad.
Absolutely. A high-quality image versus a useless one, especially in trauma, can literally come down to whether the tech could visually estimate that IR parallel to the femoral neck or nail that 15-degree coordinated tilt for the Clemens Nakayama. It's physics and anatomy working together.
What really struck me as you explained it was that specific requirement for the Taylor outlet view, the different angular ranges based on biological sex. That 10-degree potential difference isn't trivial.
No, it's significant, and it's a concrete example right from the technical manuals showing that a single rigid protocol doesn't always work. Anatomy varies.
Which really leads to a final thought, doesn't it? We've seen how a fundamental biological difference like pelvic shape necessitates quite specific tailored adjustments in CR angulation for just one view, the Taylor outlet. So it makes you wonder, what other subtle, maybe less obvious biological variations, things like differences in spinal curvature or how bone density changes with age or even just different body types. Body habitus might require similar, highly specific, individualized geometric tweaks to our standard radiographic protocols across the entire body. Are we fully accounting for these variations everywhere?
That's a really provocative question. We know 10 degrees matters hugely in the pelvis. Where else might similar precision be needed, but perhaps isn't standard practice yet?
Exactly. Something for you, the listener, to think about or maybe even explore further. How much more personalized could radiographic geometry become?